Today we'll be discussing about anaphylaxis, which is one of the very serious concerns in those who have known allergies, and if not treated on time, it can be fatal. So we do have a kind of definition, that is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. Severe anaphylaxis is characterized by potentially life-threatening compromise in airway, breathing, and/or the circulation. And may occur without typical skin features. So skin features can start in any allergic reaction, but you will not call everything as anaphylaxis unless you're seeing ABC compromise. So without skin features or circulatory shock being present, you cannot call it as anaphylaxis. So mostly the anaphylaxis is a kind of clinical diagnosis. So what are the characteristics? So it should be sudden and with rapid progression. So it should have ABC compromise, either airway, breathing, or circulation. So the skin or mucosal changes like flushing, urticaria, or angioedema by themselves without these ABC compromise cannot be considered as anaphylaxis. So the diagnosis is supported if they are exposed to an allergen that is known to affect them. However, most of the times, about almost 30% of the times, the allergen is unclear. The patient will not be able to recollect what caused them. But if you are in doubt, you can go ahead with IM adrenaline injection and then ask for expert opinion. So as I said, the skin and mucosal changes by themselves are not a sign of anaphylaxis. So if sometimes these skin changes and mucosal changes can be simple, subtle changes, or some of them may not even have. So 10 to 20% of people will not have any skin mucosal changes. So they directly present with bronchospasm or hypotension. And any GI symptoms like nausea, abdominal pain, or vomiting, in the absence of ABC, again, do not fall into the category of anaphylaxis. So these are mostly going to indicate what's causing this. So most of the anaphylaxis is due to insect sting or bites, venomous, all those things will cause GI symptoms. So this anaphylaxis is like a spectrum. It can be a mild allergic reaction going on to the severe anaphylaxis. So if it's a mild local skin symptoms or swelling of just part of the face or lips, it's mild. That can again progress to generalized skin reactions. And these two do not fall into the category of anaphylaxis. But if they have any ABC compromise, with or without skin symptoms, we call it as anaphylaxis. And anaphylaxis can sometimes be severe anaphylaxis also. So the trigger, what caused this, is going to depend on individuals. So most common, you have food, drugs, and venom. These are the three categories. In this, in young people, it's the food. In elderly, it's due to drugs. So in young people, less fatal in preschool kids, but it can be risky in teenagers and adults up to 30 years. In elderly, the most most of them will have comorbidities. So that's going to predispose them to fatal anaphylaxis. And some of them will be on antihypertensives like beta blockers and ACE inhibitors, in whom the adrenaline action will be less effective compared to the others, especially in beta blocker users. So coming to hospital admissions versus fatality, and the admissions are mostly due to food related anaphylaxis in youngsters. The blue line is going to indicate food related. This is the age on the x-axis. And iatrogenic medication related, as the age goes by, obviously people tend to get comorbidities, and that's going to affect. Next is the insect stings. Similarly, coming to fatal anaphylaxis, most of the times the fatal anaphylaxis is relevant to iatrogenic and probable iatrogenic in elderly people, whereas in youngsters it is because of food. So severity is going to depend on which kind of food and which kind of medication it is. So anaphylaxis and fatal anaphylaxis. So in the food, medications that can cause anaphylaxis are antibiotics like coamoxiclav, teicoplanin, or neuromuscular blocking agents, chlorhexidine. Again, coming to fatal, NMBS, then antibiotics like penicillins and cephalosporins, contrast media, and NSAIDs. Insect stings are not that popular in this category, but 6.5% of anaphylaxis and 14% of anaphylaxis related death, that is fatal anaphylaxis, are caused by insect stings. And some people have a tendency of recurrence. We don't have the statistics for India, but for in UK, 1 in 12 per year in the UK, and in the USA, 2.6 to 3.6 per 100% years. So that is the risk of recurrence. And when it comes to the fatality, so which one is going to kill the patient faster? So any drug that is injected, so it is going to affect very early. This yellow lines represent the drug injected drug that is causing anaphylaxis. So it is going to reach the entire body faster, so that can kill faster. Whereas food will take a lot of time to enter into the body, and so food related, there is a delay in the fatal anaphylaxis. So this is the time to cardiac arrest in minutes. So injected drugs are going to kill faster. So what is going on because of this allergy? So in anaphylaxis, there is redistribution of blood fluid. So there is extravasation of fluid that is going to cause airway edema, and that leads to bronchospasm. And fluid extravasation can also cause reduced venous return, that in turn can cause reduced cardiac output. So when the cardiac output is reduced, pulmonary blood flow will reduce, and also because of bronchospasm, there is reduction in pulmonary blood flow. When there is bronchospasm, the pressures inside the lung arteries and veins will be high, so there is reduced pulmonary flow. Together, they cause hypoxia. So bronchospasm and reduced pulmonary blood flow, together they cause hypoxia. And even the airway edema can also lead to less delivery of oxygen into the lungs, and that can also lead to the hypoxia. So reduced cardiac output can also cause hypotension. And there is something else going on in anaphylaxis, that is vasodilatation. So when there is vasodilatation, there is again reduced venous return to the heart, and cardiac output will reduce, hypotension will ensue. And because of hypotension, you have reduced coronary perfusion. Again, because of this, the heart will start to malfunction. There is again reduced cardiac output. This is like a vicious cycle. And because of hypoxia and hypotension, there is inadequate tissue perfusion. So one is less oxygen delivery, the other is less blood delivery. So together you have inadequate tissue perfusion, and eventually we call this as shock. So this is the pathophysiology of anaphylaxis. So when you receive an anaphylaxis suspected patients, there are, depending on the symptoms they're having, you may have to place them in different positions. So about 35% of blood volume is extravasated into some other tissue planes within 10 minutes. So if they are unstable cardiovascularly, so in them you can just put them in a flat supine position and raise the legs. So it will cause increase in venous return. So if someone is having only respiratory symptoms, so cardiovascular, they are stable, but only respiratory symptoms they are exhibiting, in them just semi-recumbent position is better. If someone is pregnant, we may have to put them in left lateral position, or if you are trying to put them in supine position, you will have to displace the uterus to one side to avoid the aorta cable compression. So presentation by trigger. So food is the most likely cause in most preschool age, and they mostly present with breathing problems, which is less rapid, and some of them will have, most of them will have history of either asthma or atopy. Medication related, mostly in elderly because they'll be having comorbidities and we'll be putting them on medications. So that will cause circulation problems. Breathing problems will be less likely. So it is going to be a rapid onset, and they may not have a history of asthma or atopy. So venom from stings or bites. It can occur in any age. Whoever is bitten, they can have this. So again, similar to the medication, they will have circulation related issues. Again, this is going to be rapid in onset. So history of atopy or asthma is uncommon again. So coming to the issues, so they will have ABC issues. So airway related, there can be airway swelling. It can be just throat or tongue. So eventually it can cause hoarseness in the voice and stridor. Stridor is nothing but inspiratory noise by upper airway obstruction. Coming to breathing, because of bronchospasm, they will have to use more muscle power, so increased work of breathing. So bronchospasm can lead to persistent cough also. That effort of breathing will eventually lead to fatigue and can cause respiratory arrest. Hypoxemia will also be there. So most of the times it can look like life-threatening asthma. Sometimes we can't even differentiate whether they're in life-threatening asthma or an anaphylaxis. In that case, it will not harm in trying adrenaline IM dose. So give adrenaline if in doubt. So signs of shock, they can have pale clammy peripheries and significant tachycardia will be there, and hypertension could be there. So only in peri-arrest scenarios or in case of insect and venom related anaphylaxis, sometimes they might have bradycardia. So circulatory collapse will lead to dizziness, decreased or lost consciousness, arrhythmias and cardiac arrest. So GI symptoms most likely indicate insect bite or sting or snake bite or parenteral drugs. Because of these issues, they are having GI symptoms. So when it comes to skin changes, so skin changes are typically the first feature of most of the allergic reactions. So almost 80% of them tend to have it. So as you can see here, you can have patchy skin lesions. So they can be simple subtle patchy arrhythmias or dramatic generalized rash could be there. So these changes can be isolated to either skin or mucous membranes like lips and tongue or both. There may be urticaria like this, which can be pale, pink or red and can be different shapes and sizes. Angioedema is swelling of deeper tissues in the neck and throat. So it can involve eyelids, lips, tongue and throat. So although the skin changes can be worrying, without life-threatening ABC problems, you cannot call this as anaphylaxis. So there are some conditions that can actually mimic anaphylaxis. There are life-threatening conditions like life-threatening asthma, hypertension, other mimics like inducible laryngeal obstruction, previously called as vocal cord dysfunction, ACE inhibitor-induced angioedema. These can be life-threatening. Whereas non-life-threatening mimics will be, they simply respond to simple measures. So fainting like vasovagal attacks, panic attacks, breath holding episodes in a child, spontaneous urticaria or angioedema, all of these could be your differentials. So once you are suspecting anaphylaxis, it's time to manage because every minute of delay can cause a fatal outcome. So try to remove the trigger. If it's because of an IV infusion or something, remove it. If it's a bee sting, remove it. So don't try to make the patient vomit. don't delay definitive treatment. So if it's taking time to remove the bee sting, first start your management, and while someone is at treatment, you can try to remove the trigger. So if there is cardiac arrest in anaphylaxis scenario, so in that case, giving IM adrenaline is not going to be reliable, because that, as the circulation is poor, the muscle may not be perfused properly, and the IM adrenaline will not enter the body properly. So in that case, you can use IV or IO access for adrenaline as per ALS guidelines. So that is, in ALS guidelines, we use 1 milligram of epinephrine, that is adrenaline. But for IM adrenaline, we use 0.5 mg. So prolonged resuscitation may be successful, just like how we do for hypothermia patients. You may have to continue your resuscitation for a long time. So special category like anaphylaxis during pregnancy, the management is going to be similar drug management, only the positioning changes will be there. So you may need to put the patient on left lateral side so that the uterus will not fall onto the IVC or aorta, compressing it. So if they're breathing normally, you can simply put them in recovery position like this, and then you may lower the head end. So with or without head end lowering, you can put them on recovery position. If you want to put them on supine, say you want to intubate or something, in that case, you will have to displace the uterus with hands manually to the left side. So if the anaphylaxis is severe in a pregnant and it's refractory to your medications, it's not settling down, in that case, you may have to consider early peri-arrest cesarean section. So involve the obs team immediately. So how much adrenaline should be given and how to deliver it? So IM is first line. Even if you have an IV access present in anaphylaxis, it's always advisable to go with IM route. That is with either 21 or 23 gauge needle. The location is anterolateral aspect of the middle third of the thigh. So even after giving 2 doses, if the patient is still having these symptoms and signs, you call it as refractory anaphylaxis. So how does adrenaline help? You have multiple actions. So via alpha action, it is going to reverse the peripheral vasodilatation and helps in reduction of tissue edema. That is the alpha action. Coming to beta, it is going to dilate the bronchial airways, so relieves bronchospasm and increases the force of myocardial contraction and suppresses the histamine and leukotriene release. And beta 2 specific actions are on mast cells, it is going to cause inhibition of activation. So that way, if you give adrenaline early, so all that inflammation can be contained. So it can attenuate the severity of IgE mediated allergic reactions. So coming to the dosage, you will be using undiluted form of adrenaline, that is 1 mg per ml solution. So in most of the Indian EDs, we have this. So we have to give anyone more than 12 years of age, you have to give 0.5 ml. So 500 mcg IM. If the kids like 6 to 12 years, you can give 300 mcg, that is 0.3 ml. 6 months to 6 years, 0.15 ml. Below 6 months, 100 to 150 mcg can be tried. If someone is above 12 years, but the child is very small for that age or pre-pubertal in them, instead of giving 500, you may give 300. So after 5 minutes, if you don't see any improvement, you may repeat 1 more dose of IM adrenaline. So about 10% will receive second dose and about 2.2% or more will be requiring more than 2 doses. So this is where we deliver the adrenaline. After giving adrenaline, sometimes there could be failure due to vasoconstriction. So sometimes it can be misinterpreted as cardiovascular compromise, and people might give more adrenaline, causing overdose. So if you have significantly increased BP, it's an indicator of overdose. So at that point, you have to stop giving any more adrenaline doses. So if there is wheeze, that means they'll be requiring more support. So wheeze can be utilized to monitor your efficacy of your adrenaline, and if to check if they need one more dose. So if you give IV, the danger is sometimes people may not dilute it, and there could be dilution errors and incorrect dosing. So IV should be given 1:10,000. Means you have to take that 1 ml, 1 mg ampule and make it 10 ml by using 9 more ml of normal saline. So nebulized adrenaline. If there is severe laryngeal edema, in them you can use adrenaline to nebulize. Again, the dose is 5 ml of IM dose, that is undiluted form 5 ml. So in them, this is an adjunct, not a replacement for IM adrenaline. So IM should be given. Along with that, you can give nebulization. So auto injectors, they are made for patient usage. So patients themselves have to use it. In the healthcare setting, it's not advisable to give auto injectors because they are very costly. And if a patient is given auto injectors, most of the times we tend to give them at least 2 units and train them before they leave the ED. So coming to oxygen, give the highest concentration to maintain 94 to 98% initially, then 88 to 92% if someone is at risk of hypercapnia, like COPD patients. Then you can use ABG to titrate. If they are in hypotension or shock, first give rapid IV bolus, 10 ml per kg in a child, or in an adult 500 to 1000 ml. So the choice of fluid is non-glucose containing crystalloids like Hartmann's or normal saline. So further fluids as needed can be given. Sometimes people might require large volumes. So whenever you are giving large volumes, if you give high chloride containing solution, there is a risk of hyperchloremia. So in such cases, you may have to use Hartmann's or plasma light rather than normal saline. So colloids themselves are a recognized risk factor for anaphylaxis. So never use colloids while treating anaphylaxis. Next, antihistamines. So these are supportive medications not to be used during emergency. So they have no role in respiratory or cardiovascular symptoms. So they can be useful in treating the skin symptoms, but again, not during emergency. So their use must not delay adrenaline and IV fluids. So once the patient is stabilized, think of antihistamines. In that, more specifically, H1 receptor antihistamines like cetirizine. Don't use H2 receptor antihistamines like ranitidine. So when you want to use H1 blockers, you have to give orally. So if oral is not possible, then you can give IM or IV, but mind you, the rapid IV injection of antihistamines themselves can cause hypotension. So oral is preferable. If oral is not possible due to some reason, you may give IM or IV. If they are less than 2 years old, 250 micrograms per kg, 2 to 6 years, 2.5 to 5 mg, 6 to 11 years, 5 to 10 mg, 12 and above, 10 to 20 mg can be given. So there is no evidence to support H2 receptor antihistamines like ranitidine. So choose cetirizine. Other supportive medications like steroids and bronchodilators. So steroids, no routine use. Consider after initial management with your adrenaline and fluid therapy if they themselves are not helping. So in case of refractory or ongoing asthma or shock. So they help with downregulation of late phase rather than the early phase. So only helpful in late phase. So if someone is having asthma, in them you can give early corticosteroids which can be beneficial. So wherever possible, give orally. So severe anaphylaxis will be looking like almost like life-threatening asthma. So if someone has asthma in the context of exposure to a known allergen in them, don't think that it is just don't think that it's just life-threatening asthma. Consider anaphylaxis and give IM adrenaline. So you can give other bronchodilators like salbutamol with and ipratropium as usual for asthma management. So when do you call it a refractory anaphylaxis? So less than 1% of cases end up as refractory. So anaphylaxis requiring ongoing treatment due to persisting respiratory or cardiovascular symptoms despite too appropriate doses of IM adrenaline. So when you give less dose adrenaline, you cannot count that as part of these 2 doses. So for example, if an adult is supposed to be given 500 mcg and you have given 300 mcg as first dose by mistake, you cannot consider that as one of these 2 doses. So 2 appropriate doses. Beyond that, if they are still having symptoms, you call it as refractory anaphylaxis. So why someone ends up in refractory anaphylaxis? Either delayed or insufficient adrenaline, or progression due to ongoing release of inflammatory mediators, or diminished response to adrenaline like tachyphylaxis. So less response to adrenaline. This is uncommon, but the first 2 are common factors. So how do you manage refractory anaphylaxis? So you'll have to take help from critical care or any other specialists available with you. So optimize the delivery of adrenaline via infusions. Infusion can be given via IV, IO or central line, and also fluid therapy. So low dose infusions are more efficient than other routes. So response to infusion can be suboptimal if cardiovascular shock is already fully established. So when you want to add one more infusion, like alternative vasopressor can be given. So even in them, first start adrenaline infusion, then consider another vasopressors. So this combination is superior to vasopressin alone. So somehow if your infusion is delayed, in that case, you may give IM adrenaline every 5 minutes till you start an infusion. So when adrenaline is on infusion, you will have to look for side effects that indicate the overdose, like tachycardia, arrhythmia, hypertension. You have to keep a watch on this. So when you are establishing an IV infusion, the patient needs to be fully monitored, BP at least every 5 minutes, and you have to use 1 mg of adrenaline in 100 ml of NS via a dedicated line. So if you are using one line to give 2 or more medications, you can use if you are using anti-reflux valve. So this like this, which allows the drug to flow in only one direction. So in that case, you can piggyback, means you can use the same IV line to give 1 or 2 medications. But otherwise, if you don't have such valves, use dedicated lines. And don't use on the same side where you have the BP cuff tied, because it can have disturbance. So in case of children and adults, if it's moderate severity, you can go with 0.5 ml per kg per hour infusion. If it's severe, 1 ml per kg per hour. So always choose the lowest effective rate and keep coming down whenever possible. So tachycardia, tremor, pallor with the normal or raised BP can indicate excessive adrenaline. So in that case, you will have to either reduce the dose or stop altogether. Even if the infusion is not helping, then you will have to involve an expert. So when you want to titrate it down, reduce the aiming to 50% of the starting rate. So don't stop it abruptly. First go down to 50%, then go down to stop mode over 30 minutes. So 1 hour after resolution of all symptoms and signs, you can start thinking about stopping the dose infusion over 30 minutes. If there is recurrence, again you may have to restart the infusion. So other supportive care, oxygenation is important than intubation. But if you do have to intubate, always involve your senior most clinician. You can use bronchodilators, fluids, adrenaline infusions, and vasopressors. But magnesium sulfate by itself can cause vasodilatation and can worsen the hypotension. So it's not the first line in case of refractory anaphylaxis. So if there is cardiac arrest during this scenario, for example, if someone is on the operating theater table and perioperative anaphylaxis because of your NMBS and all. In that case, when the BP drops below 50 mmHg itself, you'll have to start chest compressions, especially if they start to have bradycardia. So bradycardia and systolic BP below 50, there is a need for chest compressions. So cardiac arrest following anaphylaxis is a situation when prolonged CPR should be considered. So just like in your hypothermia, prolonged CPR should be done, and including extracorporeal CPR. So CPR with ECMO can be tried. Glucagon. So if someone is on beta blockers, in them the adrenaline effects are blocked. So in that case, adrenaline will not be of much help. But still, even in them, those using beta blockers should be tried with adrenaline and fluids first. If the response is inadequate, you can consider glucagon. So monitor for adverse events including hyperglycemia, vomiting, hypokalemia and hypocalcemia because of glucagon. So even in beta blocker users, first you should try adrenaline and adequate fluids. Only then think of glucagon. So what to send labs? So usually ECG, chest X-ray, urea electrolytes, ABG should be sent, and mast cell tryptase. When the diagnosis is uncertain but you are suspecting anaphylaxis, in that case you can send mast cell tryptase. But remember, a normal mast cell tryptase value will not exclude anaphylaxis. So this is how mast cell tryptase will increase. So at 1 hour, it peaks, then in about 3 to 4 hours, it comes down. So when you are taking sample, you have to take minimum 1 sample, ideally within 2 hours and no later than 4 hours. There is no point to take the sample after 4 hours. But ideally, you have to take 3 samples. Immediately after the patient lands to your ER, then 1 to 2 hours after the symptom onset, and after 24 hours post resolution of symptoms. So which can actually provide a baseline. So these are the 3 ideal symptoms. So some people have biphasic reactions, means they might look like everything has been settled, but suddenly they tend to show the anaphylaxis symptoms all over again. So in about 5%, they appear to resolve and recurrence of symptoms several hours later in the absence of further allergen exposure. So he has not been exposed to any more allergen, but still they are having the symptoms. So median time is approximately about 12 hours later. So risk factors, if the initial reaction itself was very severe, they required more than 1 dose of adrenaline, or if there has been a delay in giving first dose of adrenaline, or if they had previous biphasic reaction, these are the risk factors for biphasic reaction development. So when it comes to discharge, so fast track discharge within 2 hours of observation from resolution if they show good response to single dose of adrenaline given within 30 minutes of onset and complete resolution of symptoms, and patient has unused auto injectors that can be used by them at home if required, and they are trained in using so, and there is adequate supervision at home. If the patient is staying alone, you cannot discharge them. So all of these should be present. So good response, complete resolution, unused auto injectors, and there is some supervision at home. In that case, just observe for 2 more hours after resolution and send them home. If they have required 2 doses of adrenaline to treat the reaction, or they had previous biphasic reaction, they should be observed for minimum 6 hours after resolution. But if the patient has any of these factors, they should be observed for at least 12 hours following the resolution. Like severe reaction requiring 2 doses of more than 2 doses of adrenaline, has severe asthma or reaction which involves severe respiratory compromise, possibility of continuing absorption of allergen, like if they had an overdose or medication that the trigger medication is a slow release formulation, they present late at night and they may not be able to respond to any deterioration. So if you think that if he is sent home and after that he'll not be able to come back if there is worsening of symptoms, or emergency access is difficult for them, in that case also you can observe for at least 12 hours. So this is about the anaphylaxis. If you have any more questions, you can reach me at these following handles. If there are any more questions, you can post them in the QA section. We'll wait for a couple of minutes for you to post any questions. If not, we'll be ending the session. And regarding our future webinars, you can actually get notified on this channel. Go to Telegram, and MedMeet is the channel name, at which we'll be posting weekly webinar topics. And these webinars get recorded on Facebook. Even those Facebook links will be updated on the Telegram channel. The entire content for this has been taken from the Resus UK website. So you can go through the almost 60-page PDF. So instead of that, we could cover everything in 35 minutes. Looks like there are no more questions. So thank you very much for joining us.